Managing advanced heart failure is, well, tough enough on its own.
Uh-huh.
But when you throw kidney dysfunction into the mix, the complexity just skyrockets, doesn't it? And the stakes for our patients, they couldn't be higher.
Absolutely. In these critically ill patients, this interplay between the failing heart and the struggling kidneys often pushes us towards considering kidney replacement therapy, KRT.
Right.
And it's a decision that's just packed with nuances.
And that's exactly what we're diving into today. We're looking at a review article from the Journal of Cardiac Failure, Ibrahim and colleagues from 2025.
Hmm.
They've really gone through the role of KRT in these complex cases, the timing, the different methods, all those critical factors clinicians like you need to think about.
Yeah, our goal here is really to distill the absolute essentials from this review. We want to give critical care doctors like you listening a clearer picture of when and how KRT might fit into managing your patients with advanced heart failure and kidney issues.
Offering actionable insights without hopefully overwhelming everyone.
Exactly. Trying to cut through the noise a bit.
Okay, so let's jump right in. Just how common is this combination? Advanced heart failure and kidney dysfunction.
It's surprisingly common. The article points out that acute kidney dysfunction, so a sudden dip in kidney function, can complicate things for, well, up to half of all patients with advanced heart failure.
Half? Wow.
Yeah, and it's not a minor blip. It significantly worsens their prognosis and increases their mortality risk quite substantially.
That's a really stark number. And it's not just, two separate problems happening at once, is it? We're often dealing with cardiorenal syndrome.
Precisely. Cardiorenal syndrome isn't just about the heart not pumping up blood to the kidneys. I mean, that's part of it, sure.
Okay.
But the mechanisms are actually much more intricate. It involves things like increased venous pressure backing up to the kidneys, issues with the microcirculation, the tiny blood vessels. It's multifactorial.
Well, just optimizing cardiac output isn't always the magic bullet for the kidneys, then.
Not always, no. And that really complicates fluid management. Diuretics obviously are our first line.
Right.
But in advanced heart failure with kidney problems, their effectiveness can be, well, unpredictable. The article talks about variable bioavailability, how much drug actually gets absorbed and used, and patients just respond very differently. Things like poor gut absorption or reduced kidney blood flow itself can lead to diuretic resistance.
Right. So you can keep cranking up the dose, but if it's not getting absorbed or the kidneys just aren't responding, you're not getting the fluid off, and you might just be causing side effects.
Exactly.
So what are the key signs that, the red flags that tell us, okay, we need to seriously think about KRT now?
The review lays out several pretty clear indications. A major one is refractory volume overload. So persistent fluid buildup despite really pushing the diuretics.
Okay.
This is especially relevant in acute decompensated heart failure. And this is where ultrafiltration, mechanically pulling fluid off, might come into play.
So diuretics maxed out, patients still overloaded.
That's a big one. Then you have the significant metabolic issues.
Yeah.
Severe azotemia, that buildup of waste products, dangerous electrolyte imbalances like high potassium, or metabolic acidosis that you just can't fix medically. And the article also mentions specific uremic symptoms, signs of severe kidney failure, like pericarditis, inflammation around the heart, or encephalopathy, brain dysfunction, or even really severe GI issues. Those are strong indicators for KRT.
Those definitely sound like critical situations. Are there maybe less obvious reasons KRT might be needed here?
Yes, there are. For patients with cardiorenal syndrome who are stuck on high oxygen support on a ventilator, for instance,
Okay.
or those with persistent type 1 cardiorenal syndrome, that acute worsening of both heart and kidney function despite maximum diuretic efforts, KRT should be strongly considered then.
Right.
And it also touches on heart transplantation. Needing KRT before a transplant isn't necessarily a deal breaker for the kidneys long term, but needing it after getting a new heart, that's unfortunately linked to significantly worse outcomes.
Yeah, that makes sense. The new heart needs working kidneys. The article also mentioned that how we define acute kidney injury, AKI, can vary between studies. Why does that matter?
It really just highlights how tricky it is to assess kidney function in these patients. One study might use a creatinine bump of 0.3, another 0.5, maybe a percentage change, or a drop in GFR.
Right, different goalposts.
Exactly. And the authors emphasize that in advanced heart failure, blood flow dynamics, neurohormonal factors, they all influence these kidney markers. So it's not just about the numbers. You really have to closely watch urine output, electrolytes, urine sodium too, to get a real sense of whether the diuretics are actually doing anything for that specific patient.
So we have diuretics, and then we have KRT. What about ultrafiltration specifically for volume overload? How does it stack up against just using more diuretics?
That's a really key question. And there have been several trials looking directly at this. The Unload trial, for example, and Avoid HF, they suggested UF could pull off more fluid, lead to more weight loss, maybe improve shortness of breath, and even cut down on rehospitalizations compared to IV diuretics.
That sounds pretty good.
It did initially. These studies suggested aquapheresis, a type of UF, might be good for diuretic-resistant folks.
So why isn't UF the standard approach then if diuretics aren't cutting it?
Well, then came the KRS-HF trial, which painted a more complex picture. It didn't find a big difference in weight loss or outcomes between UF and a carefully managed, stepped-up diuretic strategy.
Ah.
And maybe more worryingly, the UF group in KRS-HF actually had higher rates of serum creatinine increases and more adverse events overall.
Oof. Okay, so that definitely puts a damper on the initial excitement.
It does. The takeaway from all these trials is really nuanced. UF can be effective for fluid removal, especially if diuretics aren't working.
Right.
But its benefits don't seem consistently superior to a really well-managed diuretic plan, especially if you match the amount of fluid removed. And KRS-HF raised real flags about potential kidney injury with UF in some patients.
Okay, so KRT, in whatever form, isn't without risks either.
Yeah.
What are the specific dangers and limitations we need to watch out for?
The review does a good job detailing these. You've got the general risks of any KRT procedure, things like allergic reactions to the filter components, equipment issues leading to hemolysis, breaking down red blood cells, and getting and keeping good vascular access can be tough, especially in patients with poor cardiovascular health already. Infection at the access site is always a worry.
Sure.
And interestingly, sometimes creating an AV fistula for hemodialysis access can actually trigger high-output heart failure in patients who are already vulnerable.
Wow, it's like solving one problem can create another.
Exactly. And specific to advanced heart failure, there are concerns around slow continuous ultrafiltration, or SCUF. Some research links a low systolic perfusion pressure, basically. The pressure driving blood through the kidneys, say below 90 millimol Hg in patients needing dialysis after SCUF, with worse kidney outcomes and higher mortality.
Right.
Aggressively pulling off fluid with euvolemia can drop perfusion to the kidneys and other organs, potentially causing more damage unless you're also using pressors to support blood pressure.
And then there are the practical aspects.
Absolutely. We can't ignore those.
Yeah.
KRT needs trained staff, it uses up significant resources, and it's, well, expensive. These are real-world constraints.
So if we decide KRT is the way to go, there are different types, different methods. Can you walk us through the main options?
The article mainly contrasts intermittent KRT, or IKRT, with continuous KRT, CKRT. IKRT, like standard hemodialysis, is usually for more urgent needs.
Okay.
It removes solutes faster, so it's good for clearing toxins, quickly fixing severe electrolyte or acid-base problems, or getting rid of uremic symptoms fast. It's even shown some benefit for acidosis and septic shock resuscitation.
So IKRT is the quicker, maybe more intense option.
Generally, yes. But that speed comes with the risk of dialysis disequilibrium syndrome neurological issues from rapid fluid and solute shifts in the brain.
Ah.
A KRT, on the other hand, is often the choice for patients who are hemodynamically unstable. Their blood pressure is shaky.
Okay.
Or those needing a lot of fluid removed after big surgeries, like cardiac surgery, patients on continuous life support, or post-transplant patients.
Because it's gentler hemodynamically.
Exactly. It's slower, continuous, so it provides more stability. You get better control over fluid and electrolyte balance, maybe less risk of damaging other organs.
Right.
You can remove fluid more gradually and potentially deliver higher total dialysis doses over 24 hours. But it is slower initially at clearing solutes, requires continuous anticoagulation for the circuit, and it's more resource-intensive staffing equipment.
Makes sense.
But interestingly, despite those theoretical pluses for stability, big randomized trials like Convent haven't actually shown a clear survival benefit for CKRT over IKRT in the general ICU population.
Really? That's surprising. You'd think the better stability would translate to better outcomes.
It just highlights how complex these patients are. Convent, for instance, found no real difference in hospital death, how long KRT was needed, time on vents or pressors, or length of stay in ICU or hospital. The article also notes a shift towards using citrate for anticoagulation in CKRT instead of heparin. Seems to lead to fewer circuit clots, less filter failure, and maybe less bleeding.
Okay. Now, within IKRT and CKRT, we also hear about hemodialysis versus hemofiltration. What's the basic difference there?
Hemodialysis mainly uses diffusion. Think solutes moving from high concentration in the blood to low concentration in the dialysate fluid across the membrane.
Hmm.
Good for small stuff like urea, creatinine, electrolytes.
Got it. Diffusion.
Hemofiltration uses convection. Think pressure pushing fluid across the membrane, dragging solutes along with it like sieving. It's better for clearing medium to larger molecules and for managing fluid volume.
And ultrafiltration, like we talked about for diuretic resistance, that's more like hemofiltration in mechanism.
Yes. UF as a standalone therapy in heart failure is primarily about fluid removal via convection. That's often the main goal there.
Okay.
It's important, though, not to confuse that with hemodialysis for patients who already have end-stage kidney disease, ESKD, plus heart failure. For them, hemodialysis is the main KRT for their kidney failure and helps with fluid overload.
Right. Two different scenarios.
Yeah. And the article mentions things like home dialysis, maybe using cooled dialysate, though a recent trial questioned that, or adjusting sodium and calcium in the dialysate for those ESKD-HF patients.
And what about these hybrid therapies, PI-KRT, SLED?
Right. PI-KRT is prolonged intermittent kidney replacement therapy. SLED is sustained low-efficiency dialysis. They're kind of in between standard intermittent and continuous.
Okay.
They run longer each day, maybe 6 hours or more, aiming for better hemodynamic stability than standard intermittent HD, especially if CKRT isn't available or needed.
A middle ground.
Sort of. Some studies suggest outcomes might be similar to CKRT regarding short-term mortality or ongoing KRT needs. Potential pluses could be once-a-day therapy, maybe better tolerated hemodynamically than short, intense HD sessions.
And finally, peritoneal dialysis, PD. You don't hear about that as much for acute kidney injury in critical care.
True, the data is more limited there, but the article suggests it can be a safe and effective option for AKI in heart failure patients.
Really?
Yeah, one trial showed it worked for removing fluid and waste products, and it might even help preserve some kidney function and improve heart function in cardiorenal syndrome with acute decompensation. There are different ways to do PD in the ICU, but definitely needs more research in advanced heart failure specifically.
Okay, so lots of options for how to do KRT, but the decision of when to start, that seems crucial. What does the article say about timing?
It definitely dives into that, and it highlights that the ideal timing is still, well, debated. It's an area of active research. Some recent work looked at biomarkers like NT-proBNP, that heart stress marker. Higher levels seem to predict a higher risk of needing dialysis or having worse kidney outcomes.
Interesting. A potential predictor.
Potentially. But there's no universal rule for when to start KRT in these patients. It really has to be individualized.
So it's that classic tension, intervene early to maybe prevent worsening versus the risks of starting KRT too soon.
That's exactly the challenge. Some older, smaller studies hinted at benefits for early KRT, maybe in post-cardiac surgery patients.
Right.
But more recent, large meta-analyses and big randomized trials, like the START-EI trial, generally haven't shown a significant mortality benefit or difference in long-term dialysis dependence or hospital stay between starting KRT early versus waiting for more standard urgent indications.
So the bigger trials aren't showing a clear win for starting early.
Not consistently, no. And some studies even suggested more adverse events in the early groups. START-EI did show less fluid accumulation with early KRT, but that didn't translate to better survival. So the current thinking is really that more research is needed to nail down the optimal timing.
Okay. The article also flags some special considerations, specific patient groups where KRT needs extra thought. Let's start with a right ventricular dysfunction. How does that change things?
Patients with significant RV failure are known to be really sensitive to fluid shifts and hemodynamic changes.
Okay.
Pulling fluid off too quickly can sometimes trigger neurohormonal activation that actually makes diuresis harder. So for these patients, CKRT, the continuous therapy, is often preferred.
For stability.
Exactly. Its slower, steadier fluid removal might cause less neurohormonal upset. A retrospective study mentioned in the article found CKRT was linked to better RV function afterwards.
Interesting.
And achieving a net negative fluid balance, getting more fluid off than going in, correlated with better RV function and lower mortality. But, you know, it's retrospective data. We need prospective studies to confirm that.
Sure. What about patients who already have end-stage kidney disease, ESKD, and then have an acute heart failure decompensation? That sounds incredibly difficult.
It really is. The article points out they're at much higher risk for hospitalizations for heart failure and higher mortality overall.
Makes sense.
Dialysis manages their ESKD, yes, and helps with the heart failure fluid overload. But they're also more prone to dialysis problems like low blood pressure or myocardial stunning, that temporary heart muscle weakness.
Right.
Ultrafiltration, especially SCUF, slow continuous UF, is often the go-to for volume overload when diuretics fail in these patients. The key is cautious fluid removal, watching hemodynamics very closely, adjusting the UF rate.
Got it. Careful UF.
And interestingly, the article brings up peritoneal dialysis again, PD, as maybe a good long-term option for ESKD patients with heart failure.
Oh, yeah.
Potentially fewer heart failure hospitalizations, maybe better symptoms and quality of life, less risk of high output failure from fistulas, more consistent volume control, and effective potassium removal, which might allow restarting crucial heart failure meds like ACE inhibitors or ARBs that often get stopped due to high potassium and kidney disease.
That's a really important point. Okay, cardiac surgery, another big area for AKI. How does KRT fit in post-operatively?
AKI is pretty common after cardiac surgery, like up to 30% of patients, and maybe 4% end up needing KRT. The article lists a bunch of risk factors, pre-op and intra-op.
Okay.
It's common just why it happens. And AKI after cardiac surgery definitely means higher mortality and morbidity. There are scores and biomarkers being looked at to predict risk.
Right.
Now, regarding when to start KRT if needed, again, some early studies suggested benefits to starting early. But the larger, more robust trials, including START-AKI again, haven't really backed that up.
So similar theme to the general AKI timing question.
Pretty much. Starting KRT before there's a clear urgent indication isn't generally recommended based on the current evidence. It might even lead to higher rates of long-term dialysis dependence or other adverse events. So the trend is towards waiting for traditional indications post-cardiac surgery.
Okay, makes sense. Lastly, let's touch on LVADs, left ventricular assist devices, and heart transplants. Kidney function and KRT are obviously huge factors there.
Absolutely. AKI happens frequently after LVAD implantation too, and it's linked to worse outcomes. Historically, needing permanent KRT when getting an LVAD for destination therapy, meaning not bridging to transplant, was seen very negatively.
Right, considered almost a contraindication.
Often, yes. But guidelines differentiate it's less of an issue if the LVAD is a bridge to transplant. And newer data actually shows that dialysis-dependent patients getting an LVAD as a bridge can have comparable one-year survival to non-dialysis patients.
Oh, interesting.
Yeah, and preoperative KRT can even be used to optimize patients before the LVAD goes in. Managing these patients on outpatient dialysis with an LVAD is complex, though needs tight monitoring, infection control, careful anticoagulation, specialized staff training, good communication.
A lot of coordination needed.
Definitely. And then for heart transplant itself, post-transplant AKI is common and bad for outcomes. But the good news is, kidney function often recovers within about 9 months, even in those who needed KRT initially. Most don't stay on dialysis forever.
That's encouraging.
For patients with significant kidney disease before transplant, combined heart-kidney transplant is being done more. Studies show a survival advantage, especially if they were already on dialysis pre-transplant.
Right.
There's evidence supporting combined transplant for patients with lower GFRs, say below 40 or 30, especially with other signs of chronic kidney disease. And there are even new policies now to help prioritize getting a kidney transplant after a heart transplant if severe kidney problems develop later.
Wow. Okay. That covers a huge amount of ground. This has been incredibly thorough. To try and synthesize this for our listeners, the critical care docs managing these really complex patients day in, day out, what are the absolute key takeaways?
I think the big themes are, first, the critical need for individualized assessment. Every patient is different. Second, the role of ultrafiltration is, well, nuanced. It's a tool, especially for diuretic resistance, but it's not a magic bullet and has potential downsides we need to respect. Third, choosing between intermittent and continuous KRT often comes down to hemodynamics and the specific clinical goals at that moment. Fourth, the optimal timing for starting KRT. It's still an evolving area, and the current evidence doesn't strongly push for routine early initiation before clear indications arise.
Okay.
And finally, remembering those special populations, patients with RV dysfunction, existing ESKD, post-cardiac surgery, or those with LVADs or undergoing transplant, they all need tailored strategies.
So we've covered a lot, but it's clear this is still a dynamic field. Research is ongoing, practice keeps evolving. What's a final thought for listeners to chew on as they face these challenging cases?
The critical point, I think, is that while we have guidelines and this growing evidence base, managing KRT in advanced heart failure is still this intricate mix of science and, frankly, clinical judgment.
Yeah.
As critical care physicians, it's vital to keep up with the research, yes, but maybe even more important is to critically evaluate that evidence, apply it thoughtfully to the unique patient in front of you, and really tailor your approach. Improving outcomes for these incredibly vulnerable patients. Well, it's an ongoing journey for all of us.